Hi, I'm Dr. Alexandra Filingeri, registered dietitian, doctor of clinical nutrition, and I'm sitting here with world-renowned plastic surgeon
Dr. Thomas Romo, a plastic surgeon in New York City. I'm here to introduce you to our new podcast, We Got Your Number.
We are here to break down evidence-based information and real-world experience, and we're going to bring in some of the top experts in the world because
We got your number. How can we improve diabetes treatment in this country?
let's bring in experts and really talk about what supplements actually
Can
help.
we improve our sleep health by using these medications?
How much protein do people really need to
Can
eat?
nutrition solve all of our problems?
What happens if someone comes off their weight loss medications?
Welcome back to We Got Your Number podcast. Today we're talking about nutritional management and pre and post-operative surgical care and all about that milieu with Dr. Ali Filingeri, my partner.
This is such an exciting topic because this is how our two worlds combine into one, right? So how do we optimize pre and post surgery? But I first just want to talk about the experience of a patient coming to see a plastic surgeon. So let's talk about a specific patient. Let's talk about a menopausal woman coming in to see a plastic surgeon. What are you seeing?
Well, first of all, we've taken out half the population, so we're dealing with women and not men, and we're dealing with menopause, which is a very decided process that happens in women. And we always say that if men went through menopause, all the cures would already have been done. So menopause has an effect, particularly on the face. And I tell patients, you can hide your body, but we can't hide our face in our society. So that face is out there. And the change in those female hormones, estrogen and progesterone, that occur perimenopausally down towards menopause, it has a profound effect on women's faces. And the two great big problems are volume loss, loss of fat, lipoatrophy, loss of muscle, sarcopenia, a loss of bone. It's not just your vertebral bodies in your hips. Systemic means total body, and it is a systemic process occurring. So they're losing fat, muscle, bone in their face. Additionally, gravity is pulling down the soft tissue called ptosis. Ptotic tissue, falling tissue, requires elevation, and volume loss requires the reinstitution of volume called volumization. And each one of those, but when you approach it that way, the aging face was what the diagnosis is called, you get a better, more natural result.
Right. And can you talk to me about the different options that women have when it comes to addressing the aging face?
Well, in sequencing, it's really important. As we were talking to Dr. Williams earlier, you want a diagnosis, then you want a treatment plan.
Right.
That's what a quality. We're not in sales and marketing. It may seem that way in this country and the way it's established, but it's a diagnosis and then it's a treatment plan. First of all, there's a sequence. Usually the upper half of the face ages about a decade prior to the lower half of the face. So most people come in for concerns and you're looking at upper face versus lower face. Now, when you look at that upper face, you have the forehead. Now, there's three muscle groups in the forehead that are moving. The inner and outer depressor muscles are pulling the forehead down. And we as human beings desire to look at a human being when we're looking at somebody to go eyes, lips, face. And if the muscles are pulling your forehead down, the way you manage that, and the way we're going to continue to manage that in the future, is by using injectable, hopefully topical, neuromodulators. Botox, which is now about 25 years old, and then there are some newer products that we inject into those muscles. If you inject the muscles, the depressor muscles, the forehead muscle will pull that brow up and open the eyes up. And you're never going to try and do that essentially from a surgical point of view,
Right.
Because you're going to end up with asymmetries. You're dealing with microscopic nerves, and it's just easier and safer. And all this has to be safe.
Right.
So it's KISS. I tell the girls every day, keep it simple, sweetheart.
Right.
And the risk-benefit ratio, a lot of benefit, little risk. So as you come down for the evaluation of the face, you start at the top, you work your way down. You've got the forehead with the muscles there, which you're treating with Botox. And then you run into the bushy brow, the brow. I had a woman say the other day, well, mine's not bushy. So, okay, it's the brow. So you run into the brow, and below the brow is the upper eyelid skin. And it's the relationship of that brow to the upper eyelid skin, which I think essentially is a curtain rod, and then there's a curtain underneath that. And if you hem the curtain, then you lock the rod down. And you have to be very careful because one thing is that if you start taking out eyelid skin as the primary procedure,
Right.
women live forever, and they live forever after menopause. And the lacrimal gland, which is in this part of the under the bony rim, produces tears in human beings. And female human beings, that gland is estrogen dependent.
Right.
So as women go through menopause, they start getting dry eye syndrome, and that upper eyelid has to be able to close without restriction. So the last thing you want to do is start taking out upper eyelid skin, usually. So there's usually both diagnoses. There's falling brow, browtosis, and there's redundant upper eyelid skin, dermatochalasia. Preferentially, if they have both those diagnoses, we use an endoscopic approach to elevate the brow several millimeters, and then if you want to take out some eyelid skin at that time, you take out less quantity, and they don't have closure problems called lag ophthalmos, because women have to be able to close their eyes. I tell people, particularly now from New York, the number of women that are 60, 70, 80 years old living in Florida are lots, and they
Right.
have to be able to close their eyes without restriction. And so that's a critical part of that evaluation. Upper face, and then lower face, it gets down to the neck, the musculature on the neck. They get bands on the neck, and that responds 30% of the time. 20% responds to neurotoxins like Botox and Xeomin and Dysport, and they don't like the bands. And then the redundant skin as well. What happens is that the neck, essentially, you elevate the neck, you're driving skin in front of the earlobe,
Right.
and that's got to be taken care of. You can't put a dart here in front of the earlobe down the jawline, so you've got to chase that skin back up behind the tragus and hide that skin. And so most of the time, you can't do an isolated neck lift, muscle elevation. You got to include the face in on that.
Right.
And these are just procedures. Now, the talked about procedure all the time is the deep plane facelift. And I keep telling people, Sam Hammer, Dr. Hammer from Dallas, invented that procedure 40 years ago. So I was out on my way to LaGuardia the other day, and somebody had a sign up. A doctor said, "I'm specialized in deep plane facelift." Well, it's been around for 40 years. So every surgeon who's gone through their accredited plastic surgery program knows how to do a deep plane facelift.
Right.
It's not something new. It's just a technique that we learn from a technical point of view, but it's predicated upon the diagnosis. What do they have? And it's usually upper face before lower face. It's got to be natural. Everybody uses the word natural. And the way you get natural is, one, not just pulling the skin, but adding volume. So when we're doing this, and we're going what's called minimally invasive procedures, MIP, we're doing fillers. And the fillers commonly used out there for aging face are hyaluronic acid.
Right.
And so you're putting that in, but you're trying to do that in the areas where they've lost volume secondary to the fat loss of menopause, the muscle loss of menopause. And if necessary, you put the fillers in, and then and since I'm a surgeon on that surgical component, I'll come back and actually put in a cheek implant at the time of surgery or a chin implant at the time of surgery to restore the architecture, because you're wrapping the facial skin around the architecture. And so you've got to be able to add volume and then pull, but pull appropriately, not too tight, so that it looks natural.
Yeah. And I think that was a wonderful explanation.
Thank you.
But I think it's important that when I started talking to you about menopause and nutrition, you said to me, "Allie, I do this every day." Right? A lot of my patients are in this age range. This is the time of their lives when they're noticing facial changes. They're noticing at the same time body changes, and they're noticing hormonal fluctuations. And how I like to think about it is, when we're working on the outside, how do we simultaneously work on the inside?
Critical. It's just so important. I mean, you are what you eat.
Right.
And the way you look is what you eat. So it's that's why you and I got together on this. I needed someone who could bring to the table the wherewithal. You know, I've been very interested in management, perioperative management, nutritional management, because managing surgical patients is not just the surgery, it's the healing. And
Right.
I've always been very involved with nutritional supplementation for postoperative and preoperative patients. The data has shown that proper nutrition patients, no matter what kind of surgery, general surgery or whatever you're taking, if you take proper nutrition, you decrease length of stay post surgery and you decrease postoperative infections.
Yeah.
So I've, for years, have been interested in this process and looking to have the comradeship of someone who could support me. Because if you go to the hospital, you know, you're talking to the other surgeons and they're kind of, I'm saying, look, you really need to do supplementation, dietary. And then the guy says, well, call the dietitian from, you know, from the hospital. And those are wonderful people, but they're just not bringing to the table what we really need, which is the recognition that diet and nutrition are so critical to improve surgical outcomes.
And I
And
think
you do that.
yes, I think a good place to start is let's talk about a malnourished patient, and then we'll work our way all the way through a patient that's going to come in for a elective cosmetic procedure.
Correct.
So when it comes to malnutrition, which is not, it is a overarching term and sometimes it's misused. Malnutrition does have a diagnosis and it does have diagnostic criteria, right? So I want to talk about when I'm seeing a patient, what is the diagnostic criteria for malnutrition? We can look at it in two ways. We can look at it as unexpected weight loss in a either 1 week, 6 month, 10-month, 3-month period, right? So I'm not talking about I have a patient that is prescribed by their physician a GLP-1 medication and they have lost 20% of their body weight in 6 months. That is not unintended weight loss. That is intended weight loss,
Correct.
which should ideally be done with a supervised nutrition intervention.
Correct.
But unintended weight loss is when the primary outcome was not weight loss. And what we tend to see is we tend to see muscle loss and simultaneous fat loss. So the first trigger that we're looking for is, have you had unexpected weight loss in the past 3 to 6 months? It's the first thing we want to ask for. And that can be something that can happen in a clinical hospital setting, but it can also happen in a outpatient setting. It can even happen in an elective setting.
Correct.
What has your nutrition status look like before you walk through the door? If you have lost, let's say 10% of your body weight in the past 3 to 6 months, you're already at nutrition risk. And what comes with being at nutrition risk? It's muscle and fat loss. There is something called the nutrition focused physical exam, and this is where worlds collide again.
Absolutely.
Where by very set criteria, there can be muscle and fat lossing. You talked about the orbital fat pads. You talked about the temporalis wasting there. But I tend to look a little bit deeper too in the sense of the protrusion of the clavicle. I tend to look for fat loss of the triceps. I tend to look for a dip or a squaring of the where the knee meets the thigh, loss of muscle in the gastrocnemius. Why do I look for these things? Because when we are starting with a poor baseline, we are starting with both fat and muscle loss. We're expecting that their post-operative outcome is not going to be great.
Correct. Yeah.
When it comes to any type of surgical setting or surgery that's happening, we're thinking it may be smaller where we know that there's not a lot of inflammation happening, but it may be bigger. So let's say we're talking about a hospital patient that's going in for a surgery on their gastrointestinal tract. And it's a big surgery. It's a long surgery. They're losing blood. They're having a lot of that inflammatory response happening. When they're healing, their body is taking proteins. And we've talked about that in the context of postoperative elective surgery. When we are looking to heal, we are not saying, let me use my adipose tissue. That would be wonderful. But our body's natural process is we are looking for amino acids. We are looking for amino acids that are going to help feed the citric acid cycle. We're looking for amino acids that are going to make neurotransmitters. We're looking for amino acids that are going to do essential body processes.
And to that end, and I'm add in to, from my point of view, I tell patients there's the tissue that's healing. Patients use the word scar, and I'm going, oh no, that's an incision line. The scar and the tissue that's forming to hold everything together and keep it in place is scar tissue, and scar tissue is not adipose and it's not lipid, it's protein. And so the building blocks of protein are amino acids. So if you want to heal, you got to be taking protein
Right.
in. And if you don't take protein in, your body's going to take it from your muscles.
Right. And we've talked about just the bare minimum, right? Don't go into surgery with a deficiency. I think we need to not look at that as the gold standard. We don't want them to have a deficiency, but we want them to be optimized. We want them to be nutritionally optimized.
Sure.
If they have deficiency, of course, we want to correct it, but we're really looking for optimal nutrition. And what is optimal nutrition? Some people don't really know. If they're going into surgery, they don't necessarily know how are they supposed to eat, right? So they don't have a functional understanding of, I need to eat 3 consistent meals per day. I need to have protein on my plate at each meal. I need to make sure that I'm fueling my gastrointestinal tract. We talked about the role of a diverse gut microbiome with multiple different sources of fiber. I need to be consuming multiple food groups that are meeting my mineral and my trace mineral needs. These are all things that are happening before the surgery process happens. Now, let's say we have a perimenopausal woman and she's noticing the very real hormonally driven changes in body composition. She's seeing more of a visceral fat accumulation. That woman may be coming to you now wanting to address the cosmetics of the face, restricting her diet because she doesn't understand how her physiology is changing.
Absolutely.
That's a unique intersection where, yes, of course, we want to address the cosmetics. I am extremely for any type of cosmetic procedure, but we also want to think of, how are you eating? How are you going into the surgery? Because if you're restricting, let's say, carbohydrates, you're restricting fats because you're fearing that your weight is going to change, you're not going to have the best post-surgical outcome that you want.
Absolutely, and it's critical in that post-operative milieu. And another stumbling point here is that we're not just talking about elective cosmetic surgery, which we do for a living, but we're talking about all surgery. And many times patients going into surgery don't feel well. They don't feel, and they don't feel like eating. So
Right.
it's a combination of patients rolling into the operating room to have surgery on their liver or on their GI tract. They're not eating well going into that in the first place. So it behooves the surgeon and the medical team to be aware of that lack of nutritional optimization that the patient's going in, because they're not eating anyway. And then afterwards, they're not eating anyway again. So you've got to add that nutritional support there.
And that's where we focus on true nutritional support. And that's when we start to get into the oral drinks and the protein supplements. And we're kind of thinking, how do we have them take in the least amount of liquid with the most amount of bang for their buck? So that's
Absolutely.
when we're looking for high amino acid concentrations. We're looking for supplements that are going to give good amounts of things like vitamin C, L-arginine, glutathione, things that we know are going to help them in the post-operative healing phase. And it is
It's
true.
critical.
There's many times.
It's as critical as not getting an infection and not bleeding, as you need that nutritional supplementation for the patient to heal better. And it's that paradigm has got to continue to change, because we want to have better outcomes for ourselves and for our family.
Let me paint the picture in 2 different scenarios. When I was the hospital dietitian, there were patients, right? And they were going into surgery, and I would go in there really excited to tell them, you really need to optimize here. This is the time where I don't want to see even 1% weight loss in 1 week, because I know that if you are in a state of hypermetabolism or critical illness, that your body's naturally favoring protein breakdown. The tough part that you talked about and the need for education is, I'm talking to a patient that's about to go into surgery.
Correct.
That patient is going like this, leave me alone. I don't want to talk to you, right? So that's when it becomes even more important, where I say, I want you to think of this supplementation as medication. If your doctor came in here and said, I need you to take X, Y, and Z because it's going to improve your post-surgical outcome, I need you to think about this drink as something that is going to improve your post-surgical outcome. Now, I spent my time working in the acute rehab. So patients that were coming post-hospital stay, post-ventilation, we have data, we have good data on indirect telemetry saying that they are hypercatabolic weeks post intubation. Their body, now that's recovering from whatever sense of severe illness, maybe it was surgery, maybe it wasn't surgery that required mechanical ventilation, they are breaking down at excessive rates that we cannot match. So intake, oral intake, supplementation becomes essential, and it's protein supplementation. But without the correct education, the patient doesn't understand that the thing that may be keeping them in the hospital is the fact that malnutrition is creeping in the back door.
Well, that's brilliant. And again, it's all about outcomes. And the people you have to train is not just the patients, but the physicians and the
Right.
healthcare people who are there taking care of these people. Because a patient may not be able to make those decisions, and our healthcare teams have to recognize that just what you said. What may be keeping them in the hospital is their inability to heal, and that may be because their nutrition is poor.
So let's talk now. We'll bring it full circle back to the elective patient, right? The patient that's coming in for an elective surgery. What can they do nutritionally? The first thing they can do is understand you are running a marathon, right? You don't train for the marathon after the marathon. You don't carbohydrate load for the marathon after the marathon. You do it so that on game day, you are ready to perform. And that's what I like to explain to them. We have to be ready. You have to enter surgery, even if it is elective, with a strong body and with a plan, because you're going to wake up from surgery. I say this a lot with my bariatric patients. I tell them, you're going to wake up from surgery and your stomach is going to be drastically smaller than it was before you went into surgery. So you better know X, Y, and Z after, right? So let's say we're talking about a patient that is post facelift. We understand the certain dietary requirements, right? You may have a little bit increased need for protein, but we also understand that you're not consuming hard foods, right? You're advised not to consume foods high in sodium, and your appetite likely, if you're coming post anesthesia, maybe, your gastrointestinal tract is a little bit backed up. How do you fuel yourself? And that's the most important thing.
Absolutely, absolutely, and it's difficult to. I know you admonish me because my nutritional education has gone vertical since you and I've been working together. But at least I've looked at it and I've gone, okay, let's get them some Ensure, let's get them let's get them fluids, what we can. But I mean, the specificity is incredible.
Let me give our viewers a little bit of a resource because I think that this is something that will be helpful. Let's say we're waking up post surgery. I want you to have a plan. I want you to think about the few days post surgery. Most likely your appetite isn't going to be great, but your energy and protein needs are going to be high. So we have to think smarter, right? We don't have to work harder, but we have to work smarter. So we have to think about, like I said earlier, what are liquids that we can consume that are going to deliver essential amino acids and anti-inflammatory nutrients? How do we prioritize and make a day after surgery plan for how we're going to hydrate ourselves? How do we make a plan knowing that you're depositing new collagen weeks after surgery? And that's saying, okay,
that's what the scar tissue is made of, and that's how you heal. It's scar tissue. It's not. It's not. That's the glue that holds the body together.
right. So thinking that your post-operative diet is not 1 week after surgery, it's not 2 weeks after surgery, but it's the full, let's say 6 months to a year that it takes to recover. And if you can put those bodybuilding nutrients into your body, you will have a good outcome.
Well, that's the goal, and that's what you and I'll be talking about in the weeks to come on We Got Your Number podcast.